I'd like to introduce our next speaker, Leanne. Leanne Wells is the Chief Executive Officer of the Consumer Health Forum of Australia and has held the executive positions within government and within national and state and non-government organisations, most recently as the CEO of the ACT Medicare Local. Leanne is the Chair of the Coordinator South East New South Wales Primary Health Network, Community Advisory Committee, as well as the Board Director on Coordinator, Board Director of AusHelp Foundation, Board Director of Pay in Australia, member of the Clinical Governance Committee of Goodwin Aged Care Services. You're very busy these days, Leanne.
I'm a busy girl. Yeah.
Welcome.
Thanks, Kim. Can everyone hear me okay? Do a little volume check. Okay. What I wanted to talk about today, thank you very much for the invitation, and I'd also like to acknowledge the traditional custodians on whose land we meet today. They're elders past and present. The question I was posed for today was, how should the primary health care system respond to people with chronic disease and complex conditions? It's pretty topical, isn't it, that one? How do we gear up to better manage how we respond to people with chronic disease and complex conditions? Big questions. As consumers, community members and clinicians, it's probably the most important question we need to ask ourselves of our health system today. It's certainly one that policymakers grapple with. But the answer to the question is not just about how we better manage care at the individual level, it's also about where our health dollar is best invested and how we sustain and improve our health system. So to give a Consumers Health Forum perspective on this question, I thought it was useful to ask in the first place why primary health care as a setting, as a concept matters, to make some comment about the patient experience of primary health care, what we know about that, to look at some of the current debates and issues about primary health care, and then to look at some useful frameworks for how we might go about strengthening, or that we might draw from as we go about strengthening and improving our primary health care system. So why do we care so much about primary health care? It's a setting where we manage most of our growing chronic disease burden. It's efficient, it's accessible, it gets good outcomes for the most part, and it's the backbone of strong health systems. But I just want to unpack that a little bit. Primary health care matters because we do have, and other previous speakers have talked to this, so I won't dwell on this, but you can see there from those figures, we have a growing chronic condition and mental health burden. And primary health care is a setting where these are most commonly prevented, diagnosed and managed. But it also matters because it's a setting where we no longer, or where you're all clinicians as I gather in the audience, are no longer dealing with single diseases, and consumers are no longer dealing with self-managing single diseases either. Comorbidity, multimorbidity is really the name of the game these days, isn't it? Primary health care matters because through this setting we can have great impact. For people at the individual level, a 2012 King's Fund report examined long-term conditions and mental health and found that improving the way we respond to comorbid physical and mental health conditions can have high impact in terms of patient experience and clinical outcomes. And the reason for this is both are substantially poorer relative to those for people with single conditions. And for the system, primary health care matters because there's consensus spearheaded by Barbara Starfield's seminal work and more recently that of Diane Kringos from the Netherlands, which tell us that the globe's highest performing health systems are the ones that have strong, well-developed, high-performing primary health care sectors. As I said, primary care matters because it's a setting where we're managing more complexity than ever. And we need to make sure it's a healthcare setting and a healthcare workforce that's supported with the right conditions, the right policies, the right funding models, the right models of care in order to do that really well. But we are starting to see some really, I think, really worrying reports from clinicians themselves about the challenges they experience caring for people with complex health needs. The Commonwealth Fund surveyed primary care doctors in 10 countries last year to determine how they viewed their capability in providing high quality care for ageing patients with increasing complex healthcare needs who will need ongoing chronic care management. The survey aimed to assess the experience of primary healthcare doctors regarding their preparedness and the preparedness of their practice and the others within their practice, in their opinion, to manage the care of patients with complex needs, children and adults, in terms of patient access, in terms of communication with other specialties and community-based providers, in terms of use of IT, all of those sorts of things. Australian GPs surveyed as part of that Commonwealth Fund study reported comparatively high levels of preparedness to manage patients with chronic and complex conditions. But if you see that first line there, if we look more carefully at the responses, we find that they felt much less prepared to deal with dementia patients, patients needing palliative care, and very relevant to the topic we're talking about this morning and today, patients with mental health problems and substance use issues. The same Australian GPs in that survey, Australian GPs surveyed about their capacity to provide enhanced access and care management also reported comparatively high levels of engaging practice nurses or case managers to monitor and manage care for patients with complex and chronic conditions. I think we've got a very good long history of and growth in the number of practice nurses in general practices, and that's been a good thing. There's no question about that. But the doctors participating in this survey reported low levels of providing home visits, provision of email access for patient queries, or online access to patients' own medical records. So these sorts of things suggest to us, I think, that we're making good use of nurses and good use of workforce in general practice, and I'm sure there's areas where that can be improved as well. You're better versed to comment on those issues than I am, I'm sure. But I think it indicates that there are other service improvements that could be made to bolster how practices manage more complex care, particularly care that requires coordination, such as outreach into settings other than the GP clinic, and much stronger uptake of techniques such as shared decision-making and shared electronic health records. And that study is pretty insightful, so it is on the Commonwealth Fund website and well worth a look, I think. So on the consumer side of things now, let's have a look at some of the data and some of the issues there. What's the experience that healthcare consumers have had with primary healthcare, particularly at the general practice level? These snippets of information here are from the ABS Patient Experience of General Practice Survey, 2014 and 15. 21% of all patients report waiting longer than acceptable, and this is an increase to 23, and this increases to 23% in rural and remote areas. Among those who saw 3 or more health professionals for the same condition, 1 in 8 reported issues caused by lack of communication between professionals, and more than 1 in 4 felt their GP did not listen carefully, and the same proportion again didn't feel their GP spent enough time with them. I think it harks back to Rosemary's presentation too about the dissonance she showed between what people wanted in terms of information and where they want to get it from. They want to hear and they want to talk to, and they want their health professionals to take the time to do that. The other issue, of course, in how ready and how prepared and how well placed the primary healthcare setting is to respond to the growing burden of chronic disease and complex and chronic conditions and the multi-morbidities that we're starting to see quite profoundly are the cost drivers. Costs of chronic disease to Medicare has more than doubled from $10 billion to almost $20 billion over the past decade. Risk factors for chronic conditions such as obesity are already at really high levels and increasing. There's potentially preventable hospitalisations for chronic disease every 2 minutes. That's a pretty amazing statistic, I think. So these stats, again, not news to you, but they tell us on the one hand that we should be investing more in preventative health at the same time as stemming the flow and stemming flows into our hospitals. So back to the question posed, how should the primary healthcare system respond to people with complex and chronic conditions? Susan Lee, the Federal Health Minister, appointed a primary healthcare advisory group mid-last year to give her some recommendations about that very question. What could the Commonwealth do, in addition to some of the measures and some of the very good measures they're already doing, to further strengthen primary healthcare and accelerate primary healthcare reform? I had the pleasure of being a member of that group, and I think Karen Booth, who's here today, there she is up there, was also a member of that group with me, along with several other clinicians and other advisors. The group canvassed some options and some ways forward in its discussion paper that was published mid-last year. That's still available on the Department of Health's website. But a key point made by the paper is that Medicare is not really fit for purpose anymore when it comes to responding to people with complex and chronic conditions. Medicare was designed as a public insurance mechanism to manage episodic, one-off care and illnesses. And its core features haven't changed in 30 plus years, whereas the health profile and health needs of the community certainly have. So some of the issues, the Primary Healthcare Advisory Group, there was a roadshow, there was a very large survey which had over 1,000 respondents. There were focus groups conducted. It was quite an expansive consultation effort. Some of the issues that came through resoundingly from that consultation are the ones listed here on the slide. And again, they're largely, from not surprisingly, a consumer and community perspective, but the key things coming through repeatedly were notions of a fragmented system, notions of providers working in isolation, not as a team, comments about the extent to which care is uncoordinated, comments about difficulty finding services. On one hand, comments about service duplication, absence or delayed services on the other, low uptake of e-health and other health technology, access problems due to a whole range of issues like cost, transport, language, mobility and remoteness, and feelings of disempowerment. We know from the work of the Australian Safety and Quality and Health Commission that over 60% of the community here in Australia has low health literacy, which I think also is a very interesting and concerning statistic. And by health literacy, I mean the skills, access to information, the skills to know about their illness, self-manage, navigate how to get services, those sorts of things. Those sorts of issues and that sort of experience and the resounding message about, we've got to do something about health literacy and the extent to which people can find pathways into services. Because if people don't know what's available, how to get it, and this goes as much for GPs too, I think. I think they're as much challenged by knowing what's available in their local community as well, often. then, we're really not, doing as well as we could be, are we? And these sorts of issues are certainly borne out in the patient stories that we routinely collect at CHF. I mean, here's one vignette that highlights the importance of having a primary healthcare system that people can understand and navigate. So this person, Michael, type 2 diabetes, talking about, returning to work, the paperwork, all of those sorts of things, but underscoring the fact that most people don't know what's available and how important it is, and again, back to Rosemary's findings, how important it is for that conversation to occur between consumer or patient and their health professional or health professional teams. The importance of asking questions and being proactive. Another two vignettes that highlight the importance of clinicians that listen and who are themselves supported with information and referral pathways for their patients. Comment there from Katie, someone with lots of multiple diseases there, how important was for her and how she reported that it was a factor in her illness management that her nurse listened to her. And the last one there from Eleanor, again about the information. The information's out there, but nobody can get it. So obviously I've just given you a bit of a taster there of some of the data and issues around the primary healthcare system and the question of how it can respond better to people with complex and chronic conditions. There's a lot more we could drill down we could do there. But what can we draw together out of all of this? These challenges, these experiences of care suggest to us that greater attention needs to be given to how we support primary health care to innovate and how we support its workforce, GPs, nurses, pharmacists and others, to be the best they can be. We need an energised primary health care workforce supported with the right education, improvement tools, models of care, funding arrangements, skills in how to engage and talk to patients, in the interest of better patient care and keeping people well and out of hospital so that they can communicate interprofessionally, coordinate and integrate care and interface in a coordinated fashion with aged hospital and community care systems. So my comment is certainly not to be critical about our primary healthcare workforce. It's the backbone of our system. My comment is really about what are the underpinnings and the enablers in terms of good policy and good education and infrastructure support and tools of the trade like shared electronic records and all those sorts of things that we need to have in place and working well so that you and your other clinical colleagues can do your job to the best of your satisfaction and your patient's satisfaction. And the issues we're canvassing here, and what I'm talking about and what you're talking about today, and what the Primary Healthcare Advisory Group explored, they're not new. We've had over a decade of inquiry and review in this space. Those of you that have been around as long as I have would recall the National Health and Hospital Reform Commission led by Christine Bennett and Nicola Roxon's Primary Healthcare Expert Group and Nicola Roxon's Preventative Health Task Force. All of those activities produced extensive reports that made sense. They were all steeped in equally extensive consultation. But I think, from our perspective at Consumers Health Forum, we've been stalled for too long. When you think about it, apart from Medicare's introduction in 1984, there's really, and you might dispute this, but there's really probably only been 3 or so other real game changers that have been introduced by the Commonwealth over the last 3 decades that have really boosted the primary healthcare system or really had an impact in terms of change and that have made a difference for consumers. I think the first of those are the advent of divisions of general practice and their follow-ons, the Medicare locals and now the primary health networks. The enhanced primary healthcare MBS items where we saw for the first time, signals through that pricing mechanism that, care is now about GP coordinated management plans, and you know, for the first time we started to see remuneration through Medicare for a limited number, granted a limited number of allied health services. But you know, I think that very much is a step in the right direction and a game changer, coupled with incentives and which evolved into more block-funded grant-style arrangements for practice nurses and mental health nurses in general practice. The primary care psychiatry reforms, I think, have been groundbreaking. Programs like Better Outcomes and Better Access. And arguably the fourth one, the Indigenous Chronic Care Package, where we've seen through general practice and through Medicare locals, you know, reasonable investment in coordinated chronic disease management for people from our Indigenous communities. But I think we are at a point where we need to rejuvenate health policy thinking, and in doing that, making sure, you know, it might sound like motherhood, but the real litmus test, I think, in all of this is, you know, the extent to which we're putting the consumer and patient at the centre of all of this. And as far as primary care goes, we've got a good system and we perform comparatively well internationally. I think what we're talking about is we can do better. It's about an improvement agenda rather than throw the baby out with the bathwater. So that brings us to now. We've got 5 live reviews in the really big ticket areas of health, led by Susan Lee, who seems, you know, very energetic health minister. I think she's very ambitious and quite genuine in the change that she wants to drive. So I think it's a really exciting time for us. And I think as patient groups and clinician groups, you know, she's listening. I think, I think the time is right to get some change happening. We've got a task force looking at doing very systematic and long-term review of all the items on the Medicare benefit schedule. We've got a review of private health insurance underway. That's one that really strikes a chord for patients in terms of the value for money they get out of our mixed public-private system. We've had, as I said, the Primary Healthcare Advisory Group examine and give the Minister recommendations about primary healthcare reform. We've got an independent panel currently travelling around doing a roadshow investigating future arrangements for the way community pharmacy should be funded after the next agreement. And we've had major reviews and policies announced around mental health and drug prevention and treatment services. And we've also got, we shouldn't forget, sort of a new on one hand, but not so new on the other hand, in that many have evolved from Medicare locals, a new regional network of what I call meso structures, primary health networks, who will serve regionally as commissioning organisations and system stewards. I think enormous potential there for really regionalised, localised, better integrated primary care, community care, hospital system work to be done there. So in all of that, we've got reviews, we've got a high energy health minister that seems to be boding well. Bringing it back to the litmus test, as I said before, if we're putting the consumer at the centre of this, what's some really useful, practical framing for that? What do they want from their health system? What is it that these reviews need to keep front and centre if they are to deliver a better response for healthcare consumers generally, but particularly for those with complex and chronic conditions? NAB Health, interestingly enough, recently formulated a set of design principles to underpin what they call a future health ecosystem. And that's them there. I think for those of us, all of us are, health consumers or patients or community members, and I think if you looked at that list there and said, I want my life made easier, I want to take ownership of my health care, I want to be empowered, I want to be respected, I want to be a partner in care, I want to be kept informed, I want to be able to access information, I want you to give me the best care you can, and I want you to reduce my costs. Those sorts of things, are what people are saying. They're the sort of barbecue conversations that people have about their healthcare all the time. this slide might be a bit busy and a bit difficult to read, but these are the principles of consumer-centred healthcare that the Consumers Health Forum have adopted. I won't go through them in detail, but again, they're the yardstick against which we'll judge whether we've got the policy settings right and implementation right. And there'll be no surprises to you on that slide there. Notions of whole person care, planning and governance, the importance of having healthcare consumers involved in governance and clinical governance and service feedback loops, right through to, how we get more enhanced, coordinated and comprehensive care, informed and shared decision making, those sorts of things. And for another set of considerations, the UK's King's Fund, very major think tank in the UK, has set out eight key forms of individual involvement, factors that play and work towards putting people in control of their own health and care. As I said, things like shared decision making, supported self-management, the involvement of families and carers, choosing a provider, taking part in research as part of your care and treatment, being involved in evaluating services through feedback. So if we are to put people in control of their own health and care, if we are to protect against fragmented care, if we are to meet the quadruple aims of better health, improved patient experience, more affordable costs, and a motivated health workforce, and do that predominantly in the primary healthcare setting, we need to be thinking whole of person and whole of system. And a framework I particularly like is this one. It's the 10 building blocks of high-performing primary healthcare. I think it provides a really practical, conceptual model that can help practices or service providers, microsystem level, in the journey towards becoming high-performing patient-centred healthcare homes. It's a framework that'll help, or I believe will help, primary health networks commission services and support the primary healthcare workforce. And it's a framework that can help policymakers frame consumer-centred policy that can, if implemented right, have a transformational effect on the way primary healthcare is delivered and patient outcome. So the building blocks there, it's 10 building blocks. There are 4 foundational building blocks. Engaged leadership, that includes clinical as well as consumer and patient leadership. Data-driven improvement. It's an American model. They talk about a concept called empanelment. The equivalent notion really is voluntary patient registration or enrolment in a healthcare home, and team-based care. And then the remaining 6 building blocks are really about some of the other factors that need to bring about healthcare home and strengthen primary healthcare. So things like team-based care, things like managing a population, whether that be your practice population, whether that be a population that a PHN is serving. What is its profile? What is its characteristics? Where are the high and low points? Where can we make most impact in terms of primary health network investments? Those sorts of questions. So in closing, there's no question, and again from a consumer perspective, there's no question that the role of consumers in the health system is changing. It's been stimulated by developments that include the work of the Australian Safety and Quality Health Commission and the fact that they have among their standards a standard that's concerned about patients as partners in care, but also things like maturing health technology assessment practices, PBAC, MSAC, those sorts of organisations that look at where services should be subsidised. Do we choose one drug over another for the PBS? Those processes now involve patients in the community very actively in those rationing decision-making, really. But also not to discount the growing maturity of the consumer community itself. So if a reformed primary healthcare system can meet those consumer needs that I've talked about this morning and CHF's principles that are widely adopted, I think, by many others, including professions, the research community, policymakers and clinicians, then I think we will be truly able to say that we've achieved the goal of working with healthcare consumers to enable them not to be users and choosers of healthcare, but makers and shapers of their healthcare. So on that note, I'll leave it there. Thank you.
Sorry, we've got some time, so does anyone have questions? Jeff's got a question.
I'm just wondering if we need an Uber for the healthcare system, something that disrupts what we currently do, that's consumer-driven, where the consumer's more in control. But where is that Uber? What's its nature?
Good question. Well, you know, I mean, I think
we're doing the PHNs is disrupting everything.
Oh, look, I think it needs to happen at bottom up and top down. I mean, I do, just picking up on Kim's point there, I do think if, and this is a big if, but I think if the primary health networks can mobilise their consumer community and their communities, I think that could be very much disruptive driver of change, particularly given the mandate they've got now too. You know, the government's very clear that they are to be commissioning organisations. I think the signs are boding well that, you know, this time round, we didn't experience that with the Medicare locals, but this time round with the primary health networks, there seems to be an appetite to give primary health networks serious money, not project money or play money, but serious money to be commissioning services at scale. You know, if that can involve the community and patients really systematically and strategically in all of the stages in that commissioning cycle of needs assessment, service development, service redesign and service evaluation, then I think, yes, big promise. And then you've got, you know, things out off to right left field at the national level, like, you know, the one big switch, those sorts of platforms. You know, I think mobilising the voice of people digitally is another really, you know, potential potent source of push for change. Yeah.
Okay, thank you. Thank you.
Thank you. Thanks, Kim.
Yeah.